The Positive Pause is a motivational-minded podcast covering topics women want to know about as they journey to and through menopause, focusing on subjects that impact women's health and healthy aging, including what it means to age healthfully. The Positive Pause features experts and influencers from a variety of industries and specialties. The information and opinions expressed on the Positive Pause are not intended to replace the services of trained professionals or to provide specific medical advice. To see the National Menopause Foundation's full medical disclaimer, please visit nationalmenopausefoundation.org.
Welcome to the Positive Pause. I'm Claire Gill, founder of the National Menopause Foundation. Joining me for this episode is Ingrid Harm-Ernandes. Ms. Harm-Ernandes has been a physical therapist for more than 38 years and began specializing in women's health more than 2 decades ago. She recently retired clinically from Duke University Health System, where she treated a wide variety of pelvic patients in the Urogynecology and Physical Therapy clinics. She was the co-director and a member of the Women's Health Physical Therapy Residency program, responsible for women's health team program development. She is board certified in women's health and pelvic floor biofeedback. In 2021, she published her book, The Musculoskeletal Mystery: How to Solve Your Pelvic Floor Symptoms. She has been a featured guest on several national and international podcasts, and I'm delighted to welcome her to the Positive Pause. Thank you so much for joining me today, Ingrid.
Oh, thank you, Claire, for having me. I'm so looking forward to our conversation.
Me too. So let's start with the basics. When we talk about the pelvic floor, what parts of the body does that encompass?
Yeah, so I love that question because it can be very, very confusing for most people to know what is the pelvic floor. I'm hearing about it, but what is that? So the basic way, I think, and the best way to understand it is it's a set of muscles that are in the base of your pelvis. So what I mean by that is you have a pubic bone in the front and you have a tailbone called the coccyx in the back. The muscles span from the front to the back and side to side to what are called your sit bones. So those bones that you sit on are sits bones. So imagine a sling or a hammock, if you will, that holds up all our organs throughout our life. So it's this wonderful mechanism of a combination of muscles called the levator ani. And there are different functions within the levator ani, but that's the term for the whole musculature. And what we want to realize, I think, that's so very important is that those muscles have so many functions. They have about 5 functions. One of them is a sphincteric function. And what I mean by that is sphincters are circular muscles that, let's say if we don't want to urinate, they're closed around our urethra where we urinate from or pee from, and they're open when we do. And same with the anal canal where we poop from. So those muscles have to be able to close and open when we need them. So that's sphincteric. Then we have a sexual function. So those muscles allow us to have intercourse, to enjoy intercourse. They're so important in all sexual function, really. And then there's a third function, and that's what we call supportive. So that description of the hammock or the sling that I was talking about, where it holds our organs up no matter what we do. Yeah. So if we cough or we sneeze or we lift something, it supports us. Then we have a function of I call it a combined function where it works with the rest of our body, our true core that lets us do everything in combination. So what I mean by that is our pelvic floor, if you think of your core as your house, so your pelvic floor is the foundation of your house. Your abdominals, not your six-pack that everybody thinks your core is, but all of your abdominals together is the front of your house. The diaphragm, where you breathe from, is the roof of your house. And the back and buttock musculature is the back of the house, right? That's your core, your house. Now, if someone were to take your foundation and maybe make it crumble or pull it out a little bit, you can imagine the rest of the house would have trouble functioning, right? That's how important the pelvic floor is in this foundational work that it does for the whole core. And then lastly, the fifth function is what we call a sump pump. It basically helps pull fluid out of the pelvis so it doesn't kind of collect in the bowl, so to speak, right? So that's 5 functions, lots of work that our pelvic floor has to do and very little recognition, unfortunately.
It's so interesting. And as you said, I think most people sort of are clueless about how important this part of the body really is. And I think when we hear pelvic, we always just think about that. We think about sexual organs versus all of the functions as a foundation of our house, as you said, that this area really does mean and really matter for our overall health. So that's really, really important for people to know. We're not just talking about one aspect of that. You're talking about all 5 aspects of that, which I love. I love that description. Thank you so much for that. So when we enter menopause, we know there are a lot of changes that happen to us, both physically, psychologically, spiritually sometimes. So how common are pelvic floor issues for women during menopause?
If we look at the scope of all women, 1 in almost 3 women have some kind of pelvic floor disorder. So if you're sitting in a room, 1 of every 3 women probably have some kind of pelvic floor disorder. But what we want to know is as we get older, the risk factors go up. We're more likely to have these disorders. And what I like right now in the menopause world is there's actually a term that's come out that I think is more accurate to what happens during menopause for the pelvic region. And it's genitourinary syndrome of menopause, or GSM for short. And it's great because it describes more of the kinds of conditions that we get in menopause. So about somewhere between 27 and 84%, and I know that's a big, big margin there, of women in menopause have these kinds of symptoms that I'll describe in a moment. And I think I'll add my own little kind of thought process in there. That wide margin that you have, I think is because so many women don't realize that these symptoms are something that can be taken care of, that it's something that they can get help for. So they don't even report it. So if you don't have people reporting it, you're not going to get that prevalence. You're not going to get that knowledge of how many women have it. So let me describe a little bit of what it is that women can potentially have during menopause. So some of the most common are urinary incontinence, urgency or overactive bladder, having to run for the bathroom all the time, right? Or not making it to the bathroom. And then there's constipation, fecal incontinence. There's pelvic pain. There's pain with sex, dry tissues. All of this all comes with menopause quite frequently. And it's something that so many women are told with, well, you're going through menopause or you're going through perimenopause. Just live with it. It's something that all women have, or, honey, go have a glass of wine and your sex will be fine. And I get so furious when my patients have told me that. It's so untrue. And, it's frustrating because it means women aren't even asking for the help that's out there, that's available to them, right? So it's really, really a shame that these conditions are so very treatable, yet just ignored because people don't know what to ask for, or even physicians and nurses aren't taught, that this is something that is treatable.
Yeah. Well, as you said, it's sort of those things that we joke about a little bit, or that we hear people joke about. And then there's also a little shame with that. No one wants to admit that they're having these issues. So they might not even bring it up to their physician or their, healthcare provider, even if that healthcare provider could do something about it. It's just, I bet it's not even asked by many healthcare providers unless a woman actually brings it up. So it shouldn't be, but it's really incumbent upon us to say, hey, here are some of the changes I'm having. And as you said, hoping you get a provider who's able to say, oh, not just, oh, that's menopause. Oh, or that's normal. Oh, that's typical. We hear that all the time when it comes to menopause symptoms. And yes, it is common. It is normal, but that doesn't mean there's not something to be done about it, as you said.
Exactly.
So let's talk about what are some of the things that we can do to minimize these symptoms for women, particularly at midlife.
Yeah. So I think There are a couple paths that are important to realize that can be extremely helpful. So I'll start with the pelvic floor itself, the foundation, as we were talking about before. So for a lot of people, they've heard of Kegels, but I don't even use the word Kegels because there's such a misconception about what that really is. And when I have my patients come in and I test them for a pelvic floor contraction, and they're saying, oh, I've been doing Kegels for years and they don't do anything. I said, well, let's see what you're doing. And not only are they doing it incorrectly, they're doing something that can actually make their symptoms worse, right? So it's important for people to realize what it is. Yeah. And how you do it, right? So I can describe a little bit quickly here so people can at least get an idea of what a right pelvic floor contraction is. And if they can't do it right, then that's a real sign to go to a pelvic physical therapist. I mean, that's an absolute red flag. Time to go. So basically what I say to my folks is imagine you have a straw, and you're only imagining this. This is not really what you're doing, but you're imagining putting a straw in the vaginal canal or anal canal. And what you're going to do is you're going to use the muscles of your pelvic floor to pull fluid up through the straw. So the idea is pulling up and inward. And folks, if you're trying it out there, you shouldn't feel your buttock and your abdominals and your face and your toes get in there. You should just be feeling the pelvic floor only, pulling up and in. And then you want to feel it relax out. And that's something almost nobody talks about is, can you get it to relax? So my folks who have pain when they're doing this, they can't relax it. They can't find it. They literally can't feel themselves doing it. That's that red flag that I was telling you about, that if you're struggling with any of that, the pelvic floor PT is going to be able to assess it and guide you and put you on the right path for doing it correctly. And that's of vital importance. So, I mean, that would be that first step that I would say to folks. If you can start doing that and you can do it well, you're not having pain, you're not struggling, you start with a couple seconds up, couple seconds down, and maybe do 10 in a row a few times a day. That can make a huge difference for a lot of these symptoms that we mentioned before, particularly incontinence and so forth. But if you have pain and the pain seems to get worse or you struggle, then that's a sign that you need pelvic floor relaxation, and the pelvic floor PT can help. So that helps you kind of divide into two groups of what might be okay and what might not be okay. I actually spend 4 pages in my book describing how to do a pelvic floor contraction and relaxation. That's how important I think it is to be able to do it correctly, right? So that's number one. If you're asking, like, what can a midlife person do? It would be that to start with.
So on the Kegel exercise, we were talking about the sphincter type muscles for both the vaginal area and the anal area. When the Kegel exercise is done right, are both of those contractions happening at the same time?
Yes, indeed they are. Some people can feel it, some people can, especially if you're just starting to do it. You probably cannot discern. You'll just feel the entire region. So that's why I said for some folks, anal or vaginal, it depends on who you are and how well you feel things. So you can kind of do the imagination in either category and still get good results with it. So I find that that's why I give people the choice of what feels best when they do it. But that's a great question. Yeah.
So that's the thing, you're sort of feeling that whole area lift and secure and whatever, because that, like you said, that matters. And I want listeners to be, like you said, if you're trying this at home, you want to be able to sort of kind of get a sense of whether or not you're doing that right. And so that's important to know. So thanks for that.
So what we see now is in the beginning, we were talking about the pelvic floor itself, but we want to go out to including the true core, like we talked about before. So I'm glad we discussed that. The whole core needs to be addressed when we're talking about pelvic floor conditions. So the abdominals, the back muscles, the buttock muscles, and the diaphragm. So something that can be done every day is deep breathing in through the nose, blowing out through the mouth. Every breath we take actually activates, and the pelvic floor works along with it. So like a canister moving up and down together, every time we breathe, we help our pelvic floor. So it's great to know that something we can do every single day, no matter where we are. Breathing helps our pelvic floor. And then getting true strength for all the abdominals, not trying to get a washboard look. In fact, that's sometimes the reverse of what we want. We want to get all the abdominals going. So it's important to know that strengthening a whole core actually helps the pelvic floor work well, pelvic floor works well, the core works better. So we really should think about that. And then if I take it one other step back down to the pelvic floor, but now talking more about the skin. So during menopause, a lot of times we get some dryness. We get changes in the way the skin behaves. And it's because they are estrogen driven tissues. They respond more during menopause to those changes in estrogen. So keeping it very well lubricated, making sure you're using products that are as natural as possible. Use them daily, use during intercourse, use lubrication during intercourse, but please be careful about what you use. So there are a lot of products out there that can actually dry more. So we want to be careful about any that have a lot of preservatives in it, that have alcohol in it, glycerins, all that kind of stuff. Aloe vera, there are aloe vera products out there that can be very, very good for the tissue to use every day. So really do a little bit of research and don't use the typical, I don't want to mention products, but I'll just say the products that have preservatives and all that in that we don't want, right, is very important. So that's tissue health. And then there's another component, and that is really for everybody, is make sure you keep your fluid content up. So water. And 64 ounces is a made up number. I tell people your urine should be very, very pale yellow. It doesn't have to be clear, but really pale yellow to know if you're drinking enough fluid, because the more we're dehydrated, the drier our tissues get, the worse our muscles function, the more constipation we get, right? So water intake is hugely important, especially during the midlife time period where we sometimes don't get as thirsty as we did when we were younger. So we don't have our body saying, go ahead and drink, right? So we need to kind of make ourselves drink a little bit, right? Avoiding highly Oh, I'm sorry.
No, I was going to say that's really interesting. I didn't realize how important hydration was at midlife.
Yeah, absolutely. And then avoiding like very high caffeinated or artificial sweeteners also can make our system not work as well as it should. So it's just things to think about during midlife, I think, that can help us move through midlife symptoms that we may get better or with less of these symptoms. So it's important to know that there's many things that we can do. And then lastly, I always talk about overall well-being. So what that means is it could be something as simple as make sure you make a date with yourself to do something you like to do. So it could be, I like to take walks, but it feels really hard because everybody's pulling me in a different direction. We're the sandwich generation generally. At this time in our life, we may be taking care of our elderly parents and we're still taking care of kids or getting them through the next stages of their lives. So it's the time period where we forget about ourselves. We put ourselves on the back burner is what I always say to my patients. And you got to put yourself on the front burner. You have to realize that if you're going to take care of other people, you have to take care of yourself. If there's no other way that you can think of it, then you have to think of it that way. And I think during midlife, that's vital to repeat to yourself is go do something you like to do, go out with friends, go on a lunch date, go on a dinner date. It doesn't matter what it is. If you like it, do it. If you can get outside. So fresh air, greenery, all of that is so, so important to our overall well-being. So I think we can't ignore that component. So we put all our parts of our body together from our brain all the way down to our pelvic floor and treat everything well together. And I think during midlife, that can help people an awful lot.
That is such great advice, Ingrid. And I love that you're talking about it again, how each of the ecosystems within us interact and it impacts each other area of it, as you said, from your brain to your pelvic floor, because sometimes we're just so focused on whatever area we're having difficulty with that we don't realize that those other areas of our lives actually impact our health as well. And as you said, the overall health is so important to every woman. So thank you for that. That's really terrific advice about how to make sure that we're not just focused on the pelvic floor area, but the whole body is working well together. And that makes everything function better. So it's hard to remember that sometimes, like you said, when we're being pulled in so many different directions or have so many different responsibilities, women tend to put themselves last and definitely put our own health last. And apologies to our listeners because I'm doing the recording today with a bad cold. So I should take my own advice. But yeah, it really does matter that we put ourselves first sometimes to make sure we're able to do all of those things we want to do for our family, for our work, professional careers, for our communities, etc. So we were talking about the types of exercises and things that women can do at midlife to improve their pelvic floor health. Is there anything younger women can do now that will help them to maintain their pelvic floor health throughout their lifetime? Or is it the same activities that you just described, the same exercises you just described?
They're very much similar, very much similar. But I always said my wish would be that every 18-year-old can come into the office and get kind of this is what's happening. This is what you should think about. These are things you can do for yourself to prevent problems, right? So we want to try to capture some things so that it doesn't happen later on down the road, or it's less intense later on down the road. I think just a knowledge base, again, the book is important because it's a knowledge base for people. It's a resource for people to grow with and use through their life. So I would say some of those similar things, especially pregnancy, postpartum, and that we call it the fourth trimester because it's not just 6 weeks after you give birth. It could be months, it could be years. It really depends on the person. But if we keep calling it just postpartum, we ignore the fact that these kinds of symptoms are actually very much menopause-like. So fourth trimester is very menopause-like. And for some of us who are having babies later in life, there's almost this immediate transition from postpartum, fourth trimester, perimenopause, menopause. It just keeps going, right? So we want to make sure that we're taking care of things beforehand. And so I do suggest that for the younger folks, they really do start paying attention to some of the things that we talked about that will help be preventative. And I would say there too is take your time to go outside and walk and do things that you enjoy at the younger stage of life to make it a habit. So when you get older, it's a habit instead of, now I have to think about how do I do this? I don't want that to be for folks. I really, in my profession, what we try to do is change people's kind of mindsets, change their habits so they incorporate it into their life and it doesn't become, I have to do another thing. It's just part of their life, right? So if they start at a younger age, I think it's much, much easier to do that than try to change things later on. It's just the way our brains work. It's life. It's not something someone's intentionally doing. It is how we're kind of wired, I would say. And we can do lots to change that wiring with change in habits for sure. So unfortunately, women are kind of told for many years that cardio is the most important thing. This is what you should be doing, when really strength training is absolutely important. We need to do a combination of strength training. We need to do balance. We need to do coordination, all of that, and then some cardio with that too. So it's really a combination of things that we need to do to stay healthy rather than just focusing on one thing.
Terrific. And you referenced, again, that a lot of this is covered in your book. So let's talk about that a little bit. So what was your goal or your motivation in writing The Musculoskeletal Mystery, How to Solve Your Pelvic Floor Symptoms? How did that come about?
So I would say I was so frustrated that it was taking patients 5, 10, 20, 30 years of symptoms to finally walk through my door and be able to get help. And I felt like, what is the issue? What actually is going on? Why is there such a delay in care? And granted, when I started, almost 30 years ago now in the pelvic health world, people really didn't know about it. I mean, you think people don't now, they absolutely did not know about it. So I started to really think about it. And what happened is I realized that it's twofold. It's education on the practitioner side. So nurses, doctors, PAs didn't really know about pelvic health. It's not something they learned in school. They have to learn it afterwards, right? And then the second is patients didn't know. They didn't have the opportunity to be educated because there's nothing out there educating them on how do you ask for this kind of help? Is this the kind of help that I even should ask for, right? These conditions are common. They're not normal. It's not okay to live with them, right? So those are the big problems. And then I realized people just didn't understand what the musculoskeletal system was, that we even had muscles in our pelvic floor. Because people think it's our organs, it's our hormones. They don't think it's our muscles, right? So what we have to do is realize that the muscles, there's so many muscles in the pelvic cavity at the pelvic floor. It's rich with muscles. It's rich with what's called fascia. All of these structures are integrated in how our body functions. So the book kind of goes through all of that. So when you sit down and you look, you're like, oh, now I know why I'm having this symptom. Now I know how this works. Now I know how it should work. And then it connects it to the diagnoses, some that we already talked about. Like, why do we have incontinence? Well, a lot of it is because of the musculoskeletal system, not because of the bladder. And people want to just blame the bladder, right? So,
Right.
It's pretty amazing that when you realize the pelvic floor can actually cause the bladder or the bowel symptoms, it's like, oh, now I know I can do something with this, right? And then it describes what you get in pelvic floor physical therapy and treatment. And I did that because I had a lot of patients walk in the door who said, I'm so afraid of what you're going to do. I'm so worried. I'm so concerned. And I thought, wow, what a way to start with a patient that they're worried about what I'm going to do. So it describes how we very, very systematically and carefully go through all the different stages of what we're going to do. And we ask for consent before we do anything. And we may do what's called an internal exam. We may not do an internal exam. It really hinges on the patient and their needs. And that's really important, their patient and their needs, not their diagnosis. It's what that patient needs.
Yeah.
So I describe that in the book so the patients are not so afraid to go, or if they have to encourage a loved one to go, the loved one's not afraid to go. And then the whole back end of the book is self-care. What are some of the wonderful things you can do? So we did a little bit here on the podcast, but literally we could spend an hour on each little subject matter to help describe what you can do. But there's tons in the book to really help someone take care of all these things that we've talked about and get them on their way. And pearls of wisdom from doing this for many years is in there. And the back has lots of reputable resources so people don't go to Dr. Google and get afraid of what's going on.
Well, that's really important because that was one of my next questions is how does a patient or person find an expert in the pelvic floor region, and what should they look for when they're seeking out someone who has a specialty in pelvic floor health?
Yeah, for physical therapy itself, so pelvic floor physical therapists, they can go to our national website. It's the APTA, standing for American Physical Therapy Association. .org, and there's usually a PT Finder tab, or we have a subset is the Academy of Pelvic Health. You can get it through that tab, and then there's the PT locator there as well. When you press on that, you put your zip code in. So let's say if you're willing to drive 50 miles, you put 50 miles in it, and it will come up with pelvic health PTs in a 50-mile radius. Some will have a WCS after their name. Some will have some other letters after their name. There are a couple different subspecialties and board certifications that we can get, but they'll usually list out, they might specialize in urinary incontinence. They might specialize in pelvic pain. So you read through that and see what they have. That will help you find a pelvic PT. Urogynecologists, gynecologists, gastroenterologists, some family med physicians, they're beginning to really get a better idea. I've actually gone into family medicine practices and done a whole presentation for them so they understand better. How do they refer? How do they discover what's going on in order to send someone to the right place? So those are like, if we had to put the grouping of physicians and nurses and PAs, it would be in those categories. And the pelvic PT would be that expert to take care of the specific needs we were talking about.
And so is it like other physical therapy where most people will need to go to their primary care or family medicine doc and get a referral to a pelvic therapist?
Great question. So depending on the state. So there are states that have what are called direct access, meaning a patient can say, I know I'm leaking on coughing and sneezing. And if they have a direct access state, they can actually directly go to the physical therapist without going to a physician first. Now, if they have a more complex condition where it's a little confusing, they're not sure, I always recommend then going to a specialist because then they can order tests or things that may differentiate between what the problems can be, right? So, and the therapists themselves, the pelvic health therapist may say, if you come in without that referral and they say, something else may be going on. Let's get you over to a specialist that can discern what that may be. The therapist will do that as well, but just know there are the two directions. If you don't have a direct access state, then you do have to go to primary care or urogyn or a gynecologist, one of the other physicians first.
Okay. That's very good information. Thank you so much. I think it's really important that people know where to go to get the information and who they can talk to. And we'll make sure that we put information about the APTA and your other suggestions in the notes with this podcast so that everybody can follow up and find out what's available in their area. So we could talk about this forever, and I will definitely love to have you back on another episode because I think this is such an important topic, and we'll probably get a lot of questions from our listeners about this topic. So love that you are now part of our medical advisory committee and can help answer those questions for women when they are having more issues in this area or when they just want a little bit more information about what they can do to improve their pelvic floor health. So we've talked about so much, Ingrid, and it's really, really been fantastic. And I'm sure we'll have a ton of questions from this session. So we'll probably have to have you back on the podcast in another episode. But if we could sum up today, I'd love to know what's the most important takeaway you want our listeners to know from today's podcast?
I think for them to realize that the conditions are indeed common, but not normal. What we need to do is normalize the conversation around it, make people feel like that it's okay to talk about it, that it's okay to get help for it, that there is help for it, that they are not alone, right? I think that's one thing they're embarrassed and they don't want to reach forward and they feel like they're alone and realize they're not alone. Way in the very beginning of the podcast, we talked about how almost 1 in 3 women overall and how that statistic goes up dramatically during menopause. That I really, really want people to realize. Please go ask for the help. You can get help for everything from urinary incontinence, fecal incontinence, constipation, dryness of tissues, pain with sex, pelvic pain. I could go on, pregnancy. There's so much we can do. And please, I want people to feel like they're not alone and they can get help. So please reach out is the important thing, and talk to family and friends so everybody starts to feel like it's okay to talk about this.
That is great advice. Thank you so much for that, Ingrid. And I agree. I think if we normalize this conversation, we can make it better for future generations where they don't need to worry about what's happening to their bodies, and we can help prevent so many of these issues later in life if we have young people understanding what to do and how to protect their pelvic floor health throughout the lifespan. So thank you for that. So I really appreciate, again, you being here and sharing your expertise with us. As I mentioned earlier, we'll include additional information and resources about your book and your work and the other resources you suggested people can go to with the notes of this episode so our listeners can follow up and learn more. I hope you've learned as much as I have in this episode. And if so, please do 2 things. Subscribe to the Positive Pause podcast so you never miss an episode. And please share this information about the podcast with your family and friends. Thanks again to my guest, Ingrid Harm-Ernandes, and thank you for listening. We hope you'll tune in to another episode of The Positive Pause.